Okay, Assalamualaikum everybody. Good evening. This is Dr. Hira Salman. Welcome to our session 2. And today's topics, these are all just listed here. So first we are going to start with multiple sclerosis. So, okay, the name is here. So we'll just quickly go through the theory first. 261. Okay, here we go. So we'll just quickly revise this multiple sclerosis first, and then we will solve some recent recalls of this multiple sclerosis. Why I have chosen this topic? The reason is that you will find many questions, many recalls related to this topic, and most of them are treatment based. So we are going to emphasize more on the treatment of this multiple sclerosis. So first of all, let's start with the theory. It's an idiopathic disorder. Idiopathic means we don't know the etiology, we don't know the reason why it is happening. It's exclusively for the central nervous system. It's a disease of brain, it's a disease of spinal cord, and more common in white women living in colder climates. So we'll just memorize this point. Now, what is the most likely diagnosis? So we must have to look for the symptoms of the patient, the presentation of the patient. So we will look for multiple neurological deficits of CNS, affect any aspect of CNS, like most commonly, if we are considering any central nervous pathology, maybe the patient is presenting with blurry vision, maybe she's having some visual disturbances or because of optic neuritis. So any disorder related to brain, any disorder related to spinal cord, the presentation can be any of this, but most likely the patients are usually presented with blurry vision. After optic neuritis, the most common abnormalities are motor and sensory. So memorize the priorities of the presentation. So for example, if you're considering central nervous system, so just consider eye, just consider brain, and in that, this optic neuritis is the first one. Second most common can be of any motor and sensory that is related to spinal cord. So it can be like symptoms can be fatigue, it can be hyperreflexia and spasticity. This hyperreflexia you are going to see in your examination point of view. So of course the presentation will not be this hyperreflexia. You are going to examine this. Symptoms will not be of course hyperreflexia. You have to examine this one. And then cerebellar deficits can be of anyone. It can be any presentation with the gait, posture, and steadiness, and these are the least common findings. We are not bothered about the least findings, but this is the one sexual dysfunction, because there is a recall where it's clearly mentioned that the patient is having sexual disturbances along with blurry vision, and there you have to choose the same thing. So here the best initial and the most accurate test. So both of the tests, it's MRI. So MRI can be the best initial, can be the most accurate test in order to diagnose this multiple sclerosis. Of course, the sclerosis will be obvious during MRI. So what we are going to do, we will do first lumbar puncture as a diagnostic test. Okay, so this one is the initial thing, but the supportive test can be of lumbar puncture, where we can see mild elevation in protein, where we can see the WBC count, but it should be less than 5200. We can see this oligoclonal bands found in 85% of multiple sclerosis, not very specific, especially because we can find in other conditions as well. But so the most important one we are going to memorize here is the MRI finding, because MRI is considered to be the initial and the most accurate test, and presentation of a patient. So always look for age of the patient, gender, most commonly in female patient, especially in colder climate areas, we will see this one. And mostly the presentation can be central nervous system, or it can be related to like spinal cord in the brain, but most common is optic neuritis. And after that can be any sensory or can be any motor dysfunction. So what is the best initial therapy? This therapy is very important as far as your recalls are concerned. So here the best initial therapy is high dose steroids we are going to give, because steroids are usually what they are going to do. They are actually controlling the exacerbation. Yes, doctor.
Assalamualaikum.
Walaikum assalam.
Please explain these lumbar puncture findings.
See, lumbar puncture is not very specific. You will see WBC count, but it will not be raised because there is no as such bacterial infection, because it's mostly the sensory and motor neuron pathology. It's mostly the brain and spinal cord are involved. So here you will see, here you are not going to see any bacterial infection or any viral infection. So lumbar puncture definitely will not going to give you any clue. But because there is sclerosis, there is derangement of the deformation of the tissues of the protein. So you may find increased amount of protein. That is obvious, right? Because once the tissues are damaged, you will see lots of amounts of protein will be denatured. So eventually the protein will be high, but as such, there is no other remarkable finding in lumbar puncture. So you're not going to get anything specific rather than the protein levels, which is obvious because there is sclerosis, there is damage in the damage of the tissues. Okay.
So this is oligoclonal bands.
Yeah, this oligoclonal bands actually, once you see especially the degeneration of the tissues, degeneration of the protein. So there's a specific pattern because neurons are there, neuroglia are there. So they are arranged in a specific pattern. So you are going to see the specific bands, which are nothing but the sclerotic bands. So of course, because it's a brain pathology, you may find this bands, but it's not very much obvious because you may find in other conditions as well. So again, it's not a remarkable thing. But in most of the cases, you will find. So say, for example, you see this ANA profile, when you do this ANA antibodies, and every patient you see, especially in the SLE, but we will not say those who are having ANA positive, they are always SLE patients. So it is vice versa, something like that. So you will find in 85% of cases this band, but again, these bands are not very restricted to multiple sclerosis. You may find in other conditions of the brain as well, these band patterns. Are you getting me? So this is not very exclusive.
Yes, yes.
Exclusive thing is MRI. Once you do MRI, you will see this sclerosis up by your, especially with your eyes. So
MRI and clinical findings.
Yes, yes. So we will
MRI
give
and
this.
clinical findings, na?
Sorry.
MRI and clinical findings.
Yes, of course. So this best initial therapy, this steroids are going to do what? They are just going to control the exacerbating symptoms because, anything happening worse, steroids are the short term and they're very obvious in controlling the exacerbation. So we'll give a high dose of the steroids we can give here as well. Now, drugs that prevent relapse and progression. Here again, for your recall point of view, it's very important to memorize two drugs. So most of the time they are usually given beta interferon, but there are two very important drugs. One is glatiramer and second is beta interferon. But mostly in the recalls they are asking for this beta interferon. So these are the two important drugs that are going to prevent relapse and progression of the disease. So if they are asking you, so you need to concentrate on the question, whether the question is asking you that the patient is presenting with exacerbation, or maybe it is not clearly mentioned that it's exacerbating symptoms, but it's mentioned that symptoms are there and the patient is presented in emergency department. So you have to think about, okay, if the patient landed up in emergency, it means that there are some exacerbating factors because the patient's showing exacerbating symptoms. So there you have to choose corticosteroid, of course, the initial treatment. But if the question is saying something like what you're going to give for the progression of in order to regress the progression or in order to relapse of the disease, then you have to choose this beta interferon. It's mostly mentioned. So we have to look for the symptoms of the patient, the presentation of the patient, where the patient landed up. Then other than the like azathioprine, cyclophosphamide, they are rarely used. So we are not going to bother about this one. Now, a new multiple sclerosis treatment is started. MRI shows new multiple white matter hyperdense lesion. What is it? It's now, again, this is very important. Say, for example, the patient is already a known case of multiple sclerosis. So there are three things. The one thing, when the patient presented to you with exacerbating factors. The other thing, what you're going to give for a long-term period of time. And the third thing, the patient is already a known case of multiple sclerosis, and recently she is having some new lesions, some new pathology in the brain, or some new lesions you will find. Say, for example, the cases like progressive multifocal leukoencephalopathy. So this is the one where the patient is already a known case. You have already done MRI, you have already diagnosed your patient, but still the patient is coming up with the exacerbating, with the new lesions formation and with the new symptoms and new onset of the disease. So what you're going to do in this case, what you're going to give. So here, we have to see, mostly again you are going to control with exacerbating factors. So you will give corticosteroid, but here there are some other drugs we have to rule out. So say, for example, here it's mentioned italizumab. So this is one of the chemotherapeutic drug which is the patient is taking because of any reason, because of any pathology in her body, she is using this medication. And this is the one which is actually exacerbating her symptoms, or which is the one which is actually going to create new lesions in the brain. So we have to rule out this one as well in the history. Normally it is not mentioned, but it's there. They are asking this one, that the patient is presenting with the new lesion, what you're going to do. So again, with the exacerbating factors, you're going to give corticosteroid. For the long-term progression and control of the relapse, you're going to give this beta interferon. But you have to inquire in the history. If the patient is on natalizumab or if the patient is on any chemotherapeutic agent, we have to ask the patient to change it or to decrease the amount, whether it depends on the quantity of that drug. So say, for example, we have to measure the levels. If it's too much, we may change it to someone or change the drug regime. We have to consult with chemotherapeutic, of course, doctors. You are going to consult with oncology team. You're not going to change by yourself. So this is important. So first, let's have a look on the recalls. Okay. So here the first question says you are going to answer me. It's going to be an interactive one here now. A 40-year-old Siberian national woman recently settled in UAE, visited an OPD with complaint of blurry vision, fatigue, sexual dysfunction. On examination, hyperreflexia is present. Which of the following is most likely diagnosis? So see, 40 years Siberian. So she belongs to a very cold weather country, but she's now settled in UAE, visited an OPD with a complaint of blurry vision. Now look for the symptom of the patient. So blurry vision, fatigue, sexual dysfunction. Although sexual dysfunction is not very common, but it's there. But blurry vision, fatigue. So blurry vision, central nervous system finding is there. Fatigue, motor symptom finding is there of the spinal pathology. On examination, hyperreflexia is present. That's a very most obvious presentation or obvious finding you are going to see in your patient. So which of the following is the most likely diagnosis? What do you think? It's a multiple sclerosis, Alzheimer's, Parkinson, or Huntington? So of course, it's a very clear picture of multiple sclerosis. So based on the symptoms, based on the presentation, based on the examination finding, and based on the patient age and race, we can say it's a multiple sclerosis. No doubt in this question, right? Now, which of the following is best drug to prevent relapse and progression of multiple sclerosis? So you remember which is the best drug to prevent relapse?
Dr. Hira, please explain the other options too.
See, Alzheimer, Parkinson, they are not anyhow related. Alzheimer is dementia. Of course, when it comes to Alzheimer, always dementia comes to your mind, right? So there is no history. On the basis of history, right? You will choose. Parkinsonism, there will be gait problem, there will be motor symptoms you're going to see. There will be loss of substantia nigra. Of course, CNS pathology is there, but again, symptoms, Parkinsonian symptoms are not here, which is very typical for detecting Parkinson's disease. Huntington's disease, again, it's a dementia problem. So there is nothing like that, loss of memory, or there is no symptoms. So based on the symptoms, based on the history, based on the finding, you are going to say this is multiple sclerosis. Okay.
Okay.
So it's very obvious. Now, which of the following is best drug to prevent relapse and progression of multiple sclerosis? Here, ratification will help you. So relapse and progression. Remember what was that drug? There are two, the beta interferon and this glavon. So here the clear-cut beta interferon is there. It's a very common recall, beta interferon. We are going to use to prevent the relapse and progression of multiple sclerosis. And what happens if the patient comes to you with exacerbating symptom? What you're going to give? If there is exacerbation of the symptoms, we will give corticosteroids. Yeah, they will give corticosteroid. So corticosteroid will be your first choice for controlling these exacerbating symptoms. Second thing, for the relapse, you will give beta interferon. And third thing, already a known case of multiple sclerosis now is presenting with any new focal lesion. So you have to inquire in the history whether the patient is having this natalizumab or not. We have to change this drug if the patient is already on this one. Now, a man on treatment of multiple sclerosis present with acute onset diplopia, ataxia, and weakness of the right hand. MRI brain shows new active lesion compared to previous scans. Which of the following is the best treatment for this developer? What you're going to do? What you're going to give? He is. Are you going to give IV steroids or you're going to give oral steroids? You have to choose among these two. So it's clear, the diagnosis is clearly mentioned here that the patient is a known case of multiple sclerosis. Now he is presenting with a new lesion, new focal lesion. So there is nothing in the history of taking this natalizumab, but remember that you have to inquire from your patient. Now, which of the following is the best treatment for this development? Of course, this time he's presenting with exacerbating symptoms. We are going to give corticosteroid. Always remember, We have to give, if the exacerbating symptoms are too much, we have to start IV steroid. But it's always better to start oral corticosteroid because there is no much, change in the efficacy of this drug if you're giving via IV route or via oral route. But of course, if it's too much of symptoms, the patient cannot tolerate this one. So you have to. But here the patient is having diplopia, ataxia, right hand weakness. So these are not very much, symptoms where you have to treat simultaneously. You can give a patient a time of 6 to 8 hours to recover. So in that case, oral steroid will be good enough. So we'll give oral steroids. Now, which of the following is the most accurate test for multiple sclerosis? Remember, most accurate or best initial. Both of them will be MRI.
Doctor, please question number 3.
Question number 3. See, question number 3, you remember this point. Let me show you the point again. This point, where it's mentioned that the exacerbating factor, you are going to give high dose steroids. Remember, in order to prevent the exacerbating factors. Now, this patient is already a known case. This will fall here in this category. But the point is here, we don't have in the history, or maybe it was there in the history because it's a broken recall. But of course, you have to think about this one, that the patient must be having this, must be using natalizumab. That can result in a new focal lesion, which is known as progressive multifocal leukoencephalopathy. But it's okay if it's not there. But just think about this one, a known case of multiple sclerosis now presenting with a new focal lesion, like in this patient, in this scenario. In this scenario, the patient is already a known case. He's already on the treatment of multiple sclerosis, but again, he's presenting with some exacerbating symptoms like new onset acute onset diplopia. So where it's mentioned acute onset, it means it's exacerbating factor, right? It's not a chronic one. It's happening for the first time to the patient. Similarly, ataxia, this was not happening before, and weakness of the right hand. So he is experiencing these symptoms after the treatment of this, especially multiple sclerosis. It means that it's a new focal lesion. These all symptoms are because of the new focal lesion. So in that case, always we will consider again, these are the exacerbating factors, and based on exacerbating factors, we will give steroids. Okay, got it? Because here in this question, it's not there that the patient was having natalizumab or the patient was using any chemotherapeutic agent. There was no history mentioned here.
So
we will not go for that.
Immunoglobulins.
Sorry?
When we will give immunoglobulins?
Immunoglobulins, in order to boost the immunity of a patient. Whenever you have, and for this one, we have to have some CBC in our hand. We have to see the platelet count of the patient. We have to see the hemoglobin of the patient. Then only that, and especially platelets of your patient. So if the platelet is going down very suddenly, so there you can think of this immunoglobulins. But here in this case, no need. Because or maybe we may require this one, but we don't have any findings related to platelets, or we don't have any examination. Okay. If the level of platelets are there and decreased, then you can go for immunoglobulins. But most likely, no. Why? Because it's a known case of multiple sclerosis. So we'll always consider corticosteroid because we always have in our mind that this patient is having exacerbating factors. So we have to give steroids. And oral steroids and IV steroid, it is quite obvious that you will go for oral because depending again on the symptoms. There is no much difference in efficacy of IV and oral, especially in this patient. Okay. Now the next one is 71. Okay, so I think for this one, we have to go for the theory first. Okay, we'll go for this Parkinson disease, 258. So Parkinson starts from here. Okay, so Parkinsonism here, very important recall, which is very repeated one. Where exactly the pathology is? So the pathology is loss of substantia nigra inside the brain. So this particular part of the brain is actually not functioning, is sclerosed, is destroyed. So we have to think about this one, that always substantia nigra, if it's there in the choices or asking for the substantia nigra pathology, always related to Parkinsonism. Now, what will happen? Substantia nigra are the one which are responsible for the release of dopamine. But if there is loss of substantia nigra, there will be no dopamine. And dopamine, we know very well, it causes an inhibitory effect on our peripheral nervous system. So what will happen if there is no dopamine? There will be movement disorders. There will be tremor and gait disturbances, because muscles are going to be in a hypercontractile state. There is no one who is going to stop or who is going to inhibit the muscles contraction, because there will be no relaxation, because dopamine is not there. Dopamine is a inhibitory agonist. It's going to decrease the effectiveness of contractility, or simple words, it's going to relax the muscle. But if there is no dopamine, there will be tremors, there will be movement disorders. So what will happen? Why this substantia nigra will be lost? Maybe in case of any head trauma, maybe because from boxing, like he has mentioned. So we have to look for, again, for the presentation of a patient. Maybe patient is landing up in emergency department after having this boxing. So always consider, you can relate with this Parkinsonism. Or use of antipsychotic medications as well. Say, for example, the patient is using thorazine. So these are the medications which are actually going to act on the substantia nigra cells, and they are going to destroy them. So antipsychotic medication, especially this one, not all antipsychotics. Encephalitis, there may be infection of the inflammation of the brain. There may be receptorine. Again, these are antipsychotics. Metoclopramide, it's very exceptional. Very high doses of metoclopramide can cause this one. So it's very rare. But most commonly head trauma or infection of the brain. Say, for example, encephalitis. But always consider antipsychotic as well. But you should know the name of antipsychotic, this thorazine especially. Or sometimes, if there is nothing like that, we can say it's idiopathic. We don't know why it is happening. So what we will see in the patient, maybe for most likely, if there is infection, most likely if there is because of the use of antipsychotic, we can always see these type of disease in old patients. So 55 to 60, maybe because of the infection of the brain, or maybe because of the long-term use of antipsychotic medication. So what you're going to see in these patients, now these are the presentation. So not all of these presentation are you going to see in your patient, maybe one or two, maybe all of them. It depends. Again, the presentation, look for the history of the patient, look for the symptoms of the patient, and then decide accordingly. But Parkinson questions are very obvious very obvious. You can easily pick up those questions. So tremor will be there will be rigidity, there will be slow movements, there will be gait problem, there will be tendencies to fall because of the elderly age patient and because of the gait problems. There will be cogwheel rigidity, slowing of movement of passive flexion or extension or extremity. So when the patient is actually performing very slow movement, say for example flexion or extension, but in that particular slow movement, if there is rigidity in the muscles, you can always think of because of the dopamine deficiency, because dopamine is the one who is going to relax the muscle. Even though the patient is performing very slow movement, why rigidity is there? So that is all because of lack of dopamine. So this is called cogwheel rigidity, which is actually happening during slow movement. Fast movement, we can think of spasticity, we can think of spasm. But why in the slow movement? So because lack of dopamine. Dopamine is not excreted from the substantia nigra. Now, facial expressions limited. There will be hypomania, there will be writing is small, micrographia. So you can always relate everything where the patient is having this problem of coordination, especially the motor neurons for coordination. So what will be the presentation here again? Postural instability or orthosteric hypertension, inability of the pulse and BP to reset, lightheadedness when getting up from the seated position. This will be the presentation. So why inability of pulse and BP to reset? Because we all know very well, whenever we are sitting from standing, or we are actually standing from sitting, there will be a change in the venous pressure. So venous pressure is the one who is going to maintain your cardiac output. So you are not going to change the, if we are a normal person, we don't have something like this. So if you're standing, if you're sitting, maybe your blood pressure changes very quickly, right? But in these patients, because of the muscle rigidity, you are not going to see very obvious changes in the blood pressure. So say, for example, standing, running, and sitting, if you just check the blood pressure, it will take long time to change the reading. So this is the inability of the pulse and BP to reset. Like from standing to sitting, from sitting to standing, you can just check. So this is not going to be the presentation. This is going to be, the finding you're going to observe in your patient. Then the most frequent Parkinsonism question is, of course, treatment. What medication you are going to give? Again, treatment part is very important. So presentation, etiology is very important. Must remember substantia nigra. Whenever the word substantia nigra is there, always think about Parkinson. Secondly, this treatment option. Treatment is all depend on three conditions. Mild disease, we have to think about severe disease. Two conditions, especially mild disease and severe disease. And again, in mild disease, we have to think about which is the one who is going to control what. Say, for example, if you are considering this mild disease, we are giving medications to relieve tremor and rigidity. So this tremor and rigidity. So we will look for the especially for the symptoms of the patient. If the patient is experiencing tremor, if the patient is having rigidity on examination. So for our, he's a known case of mild disease. Like so, we will always consider anticholinergic. But when we are considering the patients who are especially older patient and they are intolerant of anticholinergic medication, they are not going to tolerate this medication, anticholinergic. So there, in that case, we will give imantidine. There is a very clear-cut recall based on this imantidine question, where it clearly says the patient is actually allergic to anticholinergic medication, or the patient, the word actually we don't know because it's a broken recall, but something like that. The patient cannot tolerate this anticholinergic. So if the patient cannot tolerate anticholinergic, what you're going to give? And he is old, 70 years old. So what you're going to give? You have to give imantidine. So just these two medications, just memorize this one, that in order to relieve the symptoms, in order to relieve the tremor, in order to relieve the rigidity of the muscle, in mild cases, you will give anticholinergic as a first line. And of course, this anticholinergic has some side effects. So these are the side effects of anticholinergic. These are the common side effects of anticholinergic, not this a specific drug. Now, imantidine, when you are going to choose imantidine in your answer choices, when it's clearly mentioned that the patient is old and he is not able to take anticholinergic, we will just try to give anticholinergic as a first line. But just in case he is not able to cope up with that medicine, we will change this to imantidine. So these 2 points, very important. Third thing, severe disease. So severe disease like inability to care for themselves, orthostatic hypertension is there, he cannot manage himself, someone has to be there every time. There you have to give this dopamine agonist. But again, when the question says which one of the following is the single most effective agent that you can give to your patient who is having severe symptoms of Parkinsonism, who is having this on and off phenomena. On and off phenomena means that when there is too much level of dopamine, what you're going to see, and when there is too much, less amount of dopamine, what you're going to see. So episodes of insufficient dopamine, like there is very less amount of dopamine, there will be bradykinesia, there will be very less movement. And when there is too much amount of dopamine, that will cause dysfunctioning in the muscle movement or in the joints. Of course, you can say dysfunctioning in the movement. But just remember one point here, one point very important. When the question says which is the single most effective medication which you're going to give your patient who is having on and off phenomena, who cannot manage themselves, and they are having on and off phenomena, means the level of dopamine up and down, up and down. Maybe you have started this patient with anticholinergic, but once you have started this anticholinergic, the dopamine level sometimes it gets very high and sometimes gets very low. So what you're going to see, this is not going to be balanced, sometimes very high, sometimes very low. Because of that, patient sometimes having bradykinesia, there is no movement, sometimes he's having difficulty in movement, or disturbance in the movement, or movement disorders. So we'll think of this levodopa or carbidopa. So there is one recall based on this as well. So you have to think about this one, that single most effective medication when the patient is not controlled on anticholinergics, or when you're going to give dopamine agonist in any condition where the patient is having severe disease. Are you getting me? Where you are going to give anticholinergic in only mild diseases. But mild disease which is not controlled on anticholinergic and your patient is old enough, so which single most effective drug you are going to give in your mild patient who is not controlled on anticholinergic, and sometimes he is presenting with on and off phenomena based on that. Sometimes he's presenting with very high movement, sometimes presenting with very low movement. So there you will give this levodopa. So levodopa will be for the severe for the severe cases. Why in the severe case we are saying started from the mild case, getting worse into the severe because ended up in on and off phenomena. So then we will give this levodopa carbidopa. And again, this one, severe disease, we can give this catecholomethyltransferase inhibitors as well. They are going to extend the duration of levodopa-carbidopa. Again, you have started with anticholinergic. Your patient is getting worse. The patient is going to show the phenomena, on and off phenomena. You have added this levodopa carbidopa, but again you are saying that your patient is not responding very well. Already you have added levodopa carbidopa, but the patient is not responding. What you're going to give? You are going to add this one, COMT inhibitor. So it's going to block metabolism of dopamine. Use only with levodopa carbidopa. Now here's a point. With anticholinergic, you can add levodopa carbidopa, but with levocarbidopa this levodopa, you are not going to add COMT in combination with anticholinergic. You have to give only two medicine. Either you can give COMT plus levodopa carbidopa, or you can give anticholinergic plus levodopa carbidopa. That's the important thing, because it's a step-up medication. A step-up medication means, first of all, you have started with this anticholinergic. Just forget about imantidine, because imantidine is only one condition in which your patient is old and your patient cannot tolerate anticholinergic. Then only you give imantidine. In otherwise, step-up medication, forget about imantidine. Just think about step one. You give anticholinergic. The patient getting worse, the patient is going to show you the phenomena, on and off phenomena. You will add levodopa carbidopa, which is the single most effective. Forget about this dopamine agonist. Then what will happen is step 3. The patient is already on anticholinergic and this levodopa carbidopa, the patient is not responding. What you're going to go? You will stop anticholinergic. You will start COMT inhibitor in combination with this levodopa carbidopa. And then when you are going to give this monoamine oxidase, again in severe cases as single agent or an adjunct to levodopa carbidopa block metabolism. So we can give this monoamine oxidase inhibitor in those patients who cannot tolerate COMT inhibitor, or maybe they have allergy to this COMT inhibitor, these medications, or the patient is not responding to COMT inhibitor. So we can just give this monoamine oxidase inhibitors. But there is one very important point with monoamine which we have to remember, and it's very important for exam point of view, as a recall point of view. The patients who are hypertensive, known hypertensive patient, in those patients we always try to avoid this monoamine oxidase, because monoamine oxidase, what they are going to do, and especially the patient, and we have to ask those patients that you have to go for the diet restriction as well. Say for example, my patient is hypertensive, cheese material, like those material who are having this tyramine containing substances. So we have to always ask these patients that please don't use this tyramine containing substances like cheese. Why? Because this tyramine is the one who is responsible for controlling blood pressure. And if your patient is on monoamine oxidase inhibitor, what will be happen? This monoamine oxidase is the enzyme which do the metabolism of tyrosine. But if you give monoamine oxidase inhibitor, it means that this inhibitor is going to inhibit monoamine oxidase. And if the monoamine oxidase is inhibited, tyramine will not function properly. Tyramine will not control blood pressure, and there will be a sudden shoot of blood pressure. So we will always be very vigilant when we are treating this this patient, especially Parkinsonian patients with monoamine oxidase. We will always consider whether the patient is hypertensive or not. And if the patient is hypertensive, we will always restrict them not to use any of these cheese products, or you have always, and all the other products, or all the other milk products which are having this tyramine containing foods. Why? Because we are going to put them on monoamine oxidase inhibitors, and because of the inhibitors there will be too much amount of tyramine, and tyramine is going to increase the blood pressure, and there will be a shooting blood pressure once the patient has started this monoamine oxidase. So there's a common recall which says that which type of food substances are contraindicated if the patient is on monoamine oxidase inhibitor therapy. So remember this tyramine containing, or if there is no mention tyramine containing, but if it's mentioned cheese, so it's okay. The product is there. You will choose the cheese from your question. So we'll just look for the question here, but we will quickly revise the medication because we are going to solve this one. Just memorize this thing, that the first line of treatment will be anticholinergic. Your patient is old, your patient cannot tolerate anticholinergic, go for imantidine. Your patient is getting worse, he's not old, he is not allergic to anticholinergic. Of course, you are not going to give amantadine, but he is now getting worse. He is on anticholinergic, but he is getting worse. Think about levodopa, carbidopa. Then again, the patient is not going to improve. Just remove the anticholinergic and add COMT inhibitors. Then again, if the patient, if there is no improvement in the patient, stop everything, and then start this monoamine oxidase inhibitor again in the severe cases. But always be vigilant with hypertensive patient that if you're giving monoamine oxidase inhibitor, you have to advise them. Dietary advice must be given to these patients. These points. Now we'll just solve these questions. We'll see. Okay. So a 71-year-old patient present with a 6-month history of decline in cognitive capacity. A conscious level on examination, the patient has bradykinesia, resting tremors, a mask-like face, and a shuffling gait. So based on the symptoms, what you're going to choose in this patient? Anyone?
Parkinson's.
And how you're going to say, if you could just revise this quickly based on the symptoms?
Because it has bradykinesia and resting tremors.
Tremor. And why all these tremors and bradykinesia is there? Because etiology is what?
Because decrease in dopamine levels.
Dopamine. Exactly. So we'll go for this.
Face and shuffling gait, all point toward Parkinson's.
Pointing towards, exactly. Now, a 71-year-old man comes to the outpatient clinic.
But why not tardive dyskinesia or others?
No, tardive dyskinesia is one particular side effect of a drug. So you cannot choose this one, right? Because tardive dyskinesia is a side effect of a drug. So we cannot choose this one because here you don't know any of the medication. You can think about it, but once you have some medication in front of you and you know, okay, this is the medication and it can cause the adverse effect of tardive dyskinesia. Haloperidol actually is the one. After taking this haloperidol, the patient experienced suddenly this tremors and suddenly this disturbance in the movement. That is called tardive. Yes.
Okay. In C, it will be lost of memory and everything.
Yes.
There will be absence of mask
So,
face.
see, if they want you to choose tardive dyskinesia, they must have given you haloperidol, or they should give you something clue that the patient has taken some medicine, and after that he is presenting in the emergency department with this disturbance gait or disturbance disturbed movement. Then you can think of course, tardive dyskinesia.
And in C and D, there will be loss of memory, and there will be no tremors and mask face and all these.
Yes, of course. And what about this Huntington's? Again, this is for this one, you will see this dementia and everything. So based on the symptoms, you can easily rule out all these diseases. The next question, a 71-year-old man comes to the outpatient clinic with difficulty walking and hand tremor at rest for the last 3 months. There is no history of trauma or past illness. General examination reveals an expressionless face. So look for the symptom, look for the age of the patient, and he is coming in outpatient clinic, right? Not landed up in emergency department. Now, slow and slurred speech and hand tremor at rest. There is no sensory abnormality, but the motor system showed brisk reflexes and hypertonia. The gait is quick with short steps and diminished associated movements such as no arm swinging. Which of the following is most probable location of the defect? So based on the symptom, very obvious symptoms, this one, mask-like face. No small motor deficits, small motor dysfunctioning of the facial muscles, slow and slurred speech, hand tremor at rest. So no relaxation of the muscle. That's why you're going to see tremor at rest, even at rest also. So what do you think?
But he's saying quick gait.
Yeah, quick. So see, reflex, because of the hyperreflexia, you may find quick gait, but again, the disturbance is there, the movement is there, the coordination will not be there. The relaxation of the muscle, the proper coordination of the muscle is not there. That's why you will see the gait problem, right? Because of the hyperreflexia, because of the hypertonia. Rigidity is also there. Tremor is also there. Think about that there is something is deficient which actually causes this all hyperactivity. So who is that one?
Quick gait means he is walking fast?
Yes. So see, say for example, if dopamine is not there and muscles are rigid, so what will happen? If he's going to take one step because of the rigidity of the muscle, you may find small steps, quick small steps, because there will be no proper relaxation of the muscle. Think about tetany. There will be no proper relaxation, right? In quick gait, what will happen? There will be
present with quick gait and also with slow, both types, huh?
But normally in quick gait we mean that small steps, small frequent steps. So why small steps? He can take a big step also, but for the big step the muscle has to have very strong contraction and very proper relaxation in between, and ATPase will be there for the proper energy, intake of the muscle. But what happened in the case of dopamine deficiency, the whole system will be lost, the whole pathophysiology will be disturbed, right? That's why you see this short steps, short movements. So this is substantia nigra. Always consider substantia nigra for Parkinson. Okay, which of the following is the most common cause of Parkinsonism? Most common cause. So what do you think? It's head trauma or use of antipsychotic, encephalitis? We can say idiopathic, but once there is no
use of antipsychotics.
No, dear. The most common is head trauma. Remember, I will just
no. Everybody is not a boxer.
That's okay, but everybody will not be taking
antipsychotic. We can say the most common cause in the sports persons like this, but everyone is not a boxer.
But head trauma.
But
or anything.
Again, look for the age of the patient. Age of the patient is mentioned. No, not mentioned. So maybe it's okay. Head trauma from boxing. It's typically mentioned head trauma from boxing. That's why maybe you're considering. But in order to choose use of antipsychotic medication, then it should be there in the question. So again, we can say it's a broken recall. We cannot clearly say this one, but it's
this question is incomplete. This is not
is incomplete. Yeah, it's broken one. So we cannot say completely. Maybe okay. Let's take in this way.
If it's mentioned, the most common cause of Parkinson in the athletes, but not.
Yes. Okay. Maybe I can just tune this question like this. Like, which of the following is the most common cause of Parkinsonism? When the patient is ended up in emergency department after having some kind of activity. That activity we don't know. So now you are clear that it should be a head trauma from boxing, or maybe it's mentioned
sports person.
He's a sports person, exactly. Or maybe if the question says the patient is a known case of any psychotic disorder, and now he's presenting with this one, then you will choose.
Then we can say the psychotic medicine.
Yes.
Dr. Hira, I need to ask one thing. Why these etiology head trauma is highlighted? Why not infections are highlighted? Because infections are common than head traumas.
You're right, but see here, because it's mentioned head trauma from boxing, that's why maybe you're confused. But if it's only mentioned head trauma, so mostly in old patients, right, they are more prone to fall. So fall in there, especially in the washrooms, in the bathroom. So yeah, age, yes. So say for example, 30 years in washroom, maybe you cannot even think about this head trauma. So, but old patient trauma, it makes sense. Or athlete is there, sportsman is there, you can always think about boxing. That's why. But see, for encephalitis, there should be something in the history like symptoms of sepsis or fever. Some presentation should be there in order to choose infection. Otherwise, you cannot choose infection.
Okay.
Okay, now here in MTB it says the most common cause of Parkinsonism is idiopathic. Now we got an answer. The most common cause of Parkinsonism is because listen. In this question, there is no significant history. We don't know the status of the patient. We don't know the age of the patient. We don't know any symptoms he's experiencing. We don't have anything. So if you don't have anything in your hand, just go with this one, idiopathic. Or if you have something in your question that pointing you towards, choose that one. Okay. So based on this point, the most common cause of Parkinsonism is idiopathic. We'll choose this one.
Okay, Dr. Hira, the Parkinsonism resulting from encephalitis, it will be reversible or irreversible?
See, encephalitis is a reversible state, but once it's go to hepatic encephalopathy, that is irreversible. Like once the complications started, then of course it will be reversible.
No, if Parkinson develops as a result of encephalitis,
yes,
it will be reversible.
Depends on the condition of the encephalitis. Yes, if the infection is cured within 72 hours, maybe usually it says 3 days, right? So it's 72 hours. So of course, Parkinsonism will be irreversible.
But if a patient is having encephalitis, I think he will be unconscious. He will be not walking. and talking and showing expressions.
Yes, so but you will see the infection when you do the examination. The patient must be unconscious. The presentation will be totally changed if he is experiencing encephalitis and presenting to you. Then then we will not bothered about Parkinson disease. We will be treating encephalitis, right? And then later on, because maybe he is on treatment of encephalitis and now he is presenting with these symptoms, we can think about this Parkinson disease. Are you getting me? So if once he is having encephalitis,
But then how
your
will
main
say
thing.
he has developed Parkinson? But then how we will say he has developed Parkinsonism?
Mostly the patients who are having encephalitis, they are not going to present, this Parkinsonian features right from the beginning. It will take some time. So say for example, when the patient is having this myocardial infarction, so this dilated cardiomyopathy will not happen in a day, right? It will take time. But when you search for the etiology, you will come to know, okay, this patient was having MI 6 months before. Now he is experiencing with this feature. So the basic
okay, old history of there will be old history of encephalitis.
Old history, yes, of course. It will not be an acute symptom because for the acute management we will not bother about Parkinson. We will only treating this encephalitis. Yeah. Okay. So which of the following medication will relieve tremor and rigidity in mild cases? Remember this one: relieve tremor, rigidity, mild cases. The first choice.
Anticholinergic.
First choice.
Anticholinergic.
Exactly. The first choice. And the first choice for the mild cases, when you are just focusing on the treatment of symptoms like tremor and rigidity, for this considered anticholinergic. Now, 65-year-old male patient recently diagnosed with Parkinson's disease is intolerant of anticholinergic. Very clear scenario. Which of the following medication is best suited? Now you will tell me. Anticholinergic, he is old, 65. What are you going to give?
Amantadine.
Yes. Okay. Which of the following medication is single most effective treatment of severe Parkinson disease? In the recall, there was no severe. I just put severe here.
Levodopa.
Or carbidopa, whatever mentioned there. Yeah. Okay. A patient should avoid tyramine-containing food substances like cheese if he is hypertensive and on treatment of which of the following anti-Parkinsonian drug? Monoamine inhibitors. Yes. So it should always be mentioned that the patient is on anti-Parkinsonian, because if we don't know the patient is on anti-Parkinsonian, then from the answer choices you can choose, because there is a relation of monoamine oxidase with the tyramine, because monoamine oxidase is the one who is going to metabolize tyramine, but inhibitor is the one who is going to inhibit the metabolism of tyramine, and there will be too much of tyramine, and there will be, because of the too much of tyramine, there will be too much hypertension, and that will be a sudden burst in hypertension suddenly after the use of this one. Okay. So for the next one, we will just do the theory first. Okay, next we have this facial palsy. I didn't get much detail from MTD, so I'll just choose this one, Ambers. Let me share that. Yeah. So for facial nerve palsy, the symptoms, especially the presentation questions are very, very, very common. So just look for the presentation of the patient. Say, for example, if we can just see the etiology of the patient, it's most common is idiopathic. The cause is not known, but acute idiopathic peripheral facial palsy is known as Bell's palsy. So the sudden loss of this facial nerve, sudden loss of palsy of this facial nerve, we can say it's a Bell's palsy, and it's very, very common, especially the term. Rather saying this facial nerve palsy, Bell palsy is the most common term. But other than that, there may be history of trauma, there may be infection that can cause like herpes zoster. But again, we are not going to concern about this one until and unless there is something in the history which is pointing you toward that, okay, this is a secondary cause of Bell's palsy. Or maybe tumor, parotid gland tumor, pregnancy can also exacerbate this one, diabetes, GBS, sarcoidosis. But we are not going to memorize all of these things. We have just think about idiopathic, think about any infection, think about any tumor, or any particular hyperphysiological state, like in the case of pregnancy, like in the case of diabetes, like in the case of sarcoidosis, amyloidosis. So, but these are very rare. Pathophysiology, Of course, these are the muscle sudden deterioration of the nerve supply of the facial muscles. That's why you're going to see. So presentation, clinical features we are going to bother most. So clinical features will be inability to frown. So there will be, you will see some central features, you will see some peripheral features. So say for example, inability to frown. So in peripheral signs are ipsilateral to the lesion. Now this is again very important because we know very well these cranial nerves, they are always decussate. Decussate at optic chiasma, especially what is that one? Optic chiasma, right? Optic chiasma, or maybe in the center you can say there always a decussation. They're always decussation. The right side of the nerve will always supply to the left part of your body. The left side of the brain always supply the right side of your body. So there because of the decussation of the motor fibers, decussation of the nerve fiber. Decussation means crossing and going to the opposite side. So because of the decussation, you will always see ipsilateral and contralateral regions.
Excuse me, Dr. Hira, not at optic chiasma. At optic chiasma, only optic nerve is decussate.
Yeah. I'm just giving you the example because this is very common. So optic word, I have used this word only to give you a clue because this is very common, the right and the left oculomotor nerve. But it's for the whole body. Now we are considering cranial nerves and the spinal nerves. So cranial nerve, starting from all the cranial nerves and the spinal nerves usually don't decussate, but all cranial nerves decussate. So they usually control the left part of the cranial nerve, usually control the right side of the body. Any cranial nerve, and it's especially the left side of the cranium will control the right part of the. So that's why the term this ipsilateral and contralateral will come. Ipsilateral means same side of the nerve will actually, if there is a damage to the same side of the nerve, the same side will be affected. That is ipsilateral, right? And if the damage of the nerve and that caused decussation was there before the damage, it will definitely cause the contralateral side damage to the muscle. So you can just imagine, we should know where the nerve is damaged, right? Before decussation or after decussation. Decussation means crossing over to the opposite side. So if it's before decussation, of course, contralateral side will be affected. But if it's after decussation, the ipsilateral side will be gone. Are you getting me? Or it's complicated. Leave it.
No. After decussation, the contralateral side, and before decussation, the
ipsilateral. But where? It should be on the cranial lesion or the spinal. So if it's cranial, above inside the brain, before decussation, ipsilateral. After decussation, contralateral. But in the spinal, we don't have anything like that, because the spinal there will be no decussation. They mostly run parallel. It only happening in the brain. That's why we are just considering oculomotor, this optic and facial, because we are very much dealing with these three nerves. Okay, so if we will just see here, this ipsilateral lesion and the contralateral lesion, so you will see inability to frown. So we are not going into the detail of this one, but inability to close the eyelid completely, mouth drooping. So these are the symptoms where you have to see where in your presentation, in your history, if the patient is presenting with these symptoms, with these signs, you will think about palsy, Tisbel palsy. What are the symptoms? Inability to frown, inability to close the eyelids, and mouth drooping. Now, what else you can see in your patient? Because these are the central lesions where you will see all these things, but maybe the peripheral part is involved. There you can see painful sensation around or behind the ear. You can see impairment of taste in the interior, and the facial nerve is also responsible. It will be do this taste, it will take or carries the taste sensations. Trigeminal also, it will carry the sensory sensations of the tongue muscles, of the especially the facial muscles. So we have to think about this one, that which part of the nerve, or not only trigeminal, this glossopharyngeal also, because glossopharyngeal is the cranial nerve, which is the 12th cranial nerve, which is responsible for the functioning or the proper functioning of the tongue muscles, or all the muscles of masticatory muscles. They are supplied by this glossopharyngeal. So actually this whole small mouth is supplied by too many nerves. Facial nerve is there, which carries the taste sensation. Trigeminal nerve is there, which carries again the sensory sensation. A part of this taste sensation, other sensory sensations, like if you touch your mouth, if you touch your face, if you touch your lips, you will feel sensation, right? That is carried through trigeminal, not through this facial nerve, but only the taste sensation will be through facial nerve. Similarly, the third thing is glossopharyngeal, which will do the motor activity. This is a highly sensitive area supplied by too many nerves. And other than that, there will be spinal nerves as well. So what we will see here, so there are some peripheral features also where you can see this taste sensation, loss of taste sensation, painful sensation, and then this hyperacusis, which is a lesion to the emergence of the nerve to the stapedius muscle, particularly ear muscles. Now dry mouth will be there. Some ocular findings are here. Now what is Bell's phenomena? A physiologic reflexive movement of the eye upward and outward that occur when the eyelid is actively closed. When you ask your patient to suddenly close your eyes, so what will happen at that time? At that time there will be a reflex movement of the eye where you can see upward and outward movement of the eye, especially that is called Bell's phenomena. That you usually ask your patient to close your eyes and they are not able to properly close it. And then this leg of ophthalmos, the patient cannot fully close the eyes. That's a common feature. Decreased lacrimation because most of the time the eyes are open. Corneal ulceration because again eyes are open. Ectropion also you will see in severe cases. So most commonly we will just go for the symptoms of the patient and signs of the patient. Most commonly they are presenting with these features: inability to frown, complete eyelid closure, mouth drooping. But you can also see this some taste sensation disturbance also in your patient, some painful sensation around and behind the ear. So what you're going to do for the diagnosis? For the diagnostic, ask about symptoms and onset and duration. Maybe it's associated with infection. Maybe the patient has gone somewhere outside the country where there's an infection, and because of the infection, the patient is having all these symptoms. But mostly it's idiopathic. And then what we will do? Treatment part again for Bell's palsy. Normally we don't do anything. But if the patient is presenting to you with acute symptoms of this one, say for example, too much lacrimation is there, too much drooping is there, the patient is having severe painful ears, something like that, acute presentation. There you can give oral glucocorticoids like prednisone should be administered within 72 hours from the disease onset. In severe cases, you may add antivirals for 1 week because we don't know the cause. We have to learn whether it's a bacterial, whether it's a viral. But for very, very acute symptoms, we can go for antivirals as well. But start with the prednisone and then you can add antivirals as well. Eye care, of course, a secondary thing. Secondary facial nerve palsy management of underlying cause. So whatever the management is there, you remember the secondary cases? So these are all the secondary one. So there may be infection, there may be virus, there may be bacterial, there may be tumors, so they are all there. So maybe whatever the secondary cause is there, we have to go for that. So if you just wait for the question. A 44-year-old woman comes to the physician as she is unable to close her left eye. There is a facial asymmetry when she smiles and inability to wrinkle the left side of her left forehead, which of the following nerves is mostly affected. So very obvious based on the symptoms. Unable to close, facial asymmetry, wrinkling is there, inability to wrinkle, left side of the left forehead, which of the following is most. Now, you will understand it's facial, but if I ask you which side of the facial, right or left, can you recognize that? Anyone?
Yeah, right. Yeah, right side. It's contralateral.
Right side, left side of the forehead.
See, the things are happening on the face. So wrinkling the left side of her left forehead. So what do you think? The right must have gone or the left must have gone?
Right.
The right must have gone. No. The left must have gone. The left must have gone because they decossate at the brainstem level.
Exactly. See, this is it's not very important, but you should know because most likely whenever the patient is having ipsilateral side effect, it must be something in the brain. Or if it's beyond brainstem, then of course you will see the ipsilateral thing. So it's most likely the left one. But here we are not bothered because we are just need to choose the nerve.
Please repeat, Dr. Hira.
Yeah. See, what should I repeat? This type of side of nerve, right or left? This one you want me to repeat?
Yes.
See, most likely they are saying that wrinkling left side of her left forehead.
There's facial asymmetry when she smiles and able to wrinkle the left side of her left forehead. Which are the following nerves the most affected? That is facial, but right side of facial.
No, listen. If it's right side of the patient, just think about this one that the nerve has ended up from the brainstem and now it's on your face.
Yeah.
Right? So now it's on your periphery. it has gone through the brain stem.
It has
Right?
decussated now.
Yeah, decussated. So if it's decussated, decussated means that what will happen? The right will control the left, and okay, then it should be the right facial. Of course, of course. Sorry, because now it comes to the face. So if it comes to the face, now it must have gone to the brain.
It will be right now.
Yeah, it will be right, exactly. Because it must have gone through the whole tympanic cavity, and now it's on your face. That's why this all facial muscles, they are controlling this wrinkling and all that. So it should be decussated at the brainstem level, and now it should be on the opposite side. So the right side will control the left. Exactly. So it should be right facial, not the left. My bad.
So before it was wrong, huh?
Yes, but before we don't have any much thing. Only maybe they are the only sensory things. But here we are not bothered because facial is not actually much to do with the sensory sensation. They are actually taking sensory sensation of taste. So taste, if it's saying something like that, then we can think about facial, left facial. If something related to taste, but here no taste. Only they are saying the muscles of the movement.
Sensory sensation is being carried over trigeminal nerve now.
Yes, that is trigeminal nerve.
Yeah.
Trigeminal has 3 branches: ophthalmic, this one olfactory, and this maxillary. That's the maxillary branch. Yes. Now, which of the following medication should be used within 72 hours of onset of Bell palsy? It's very clear cut. 72 hours of Bell palsy.
Prednisone.
Exactly. And if you want to continue for 1 week, in a patient who's having symptoms, acute symptoms, you will add as an adjunct therapy, you will add antivirals. So for here, it's prednisone because oral. And
so what's the difference between C and D? Why not corticosteroid or hydrocortisone?
They are very vague term. Now, when you have the clear-cut prednisone, why to choose this one, hydrocortisone? And this, especially prednisone, is a glucocorticoid. Prednisone is a glucocorticoid. So it should be mentioned oral glucocorticoid. Either the answer choices should be oral glucocorticoid or prednisone. Because oral glucocorticoid example is prednisone, right?
Yeah. No, but why not corticosteroids and hydrocortisone?
See, corticosteroid, hydrocortisone, and glucocorticoid, they are all different. They are all different. So this prednisone belongs to the category of oral glucocorticoids.
Okay.
So you have only 2 options. Either you can choose a broad oral glucocorticoid, or you can choose the medicine that is coming under oral glucocorticoid, that is prednisone.
Okay. So what are their category? Corticosteroids and hydrocortisone.
Corticosteroid, hydrocortisone, they are mineralocorticoid. This is the one, hydrocortisone. Corticosteroids, it's from the zona glomerulosa. I think it's released from the zona glomerulosa. So just go over this histology and let us know tomorrow, okay? But there are the zones, especially in the adrenal cortex, from where these are coming from: zona reticulare, zona fasciculata, zona glomerulosa. So from there, these especially these are coming. These glucocorticoids, these are hormones now. So particularly this one, glucocorticoids, you have to choose this one. Just remember oral glucocorticoid, right? And from where they are coming, the origin is that it's the zones of adrenal cortex from where the hormones are coming, and we have to give the same hormones from outside. So say, for example, the zona glomerulosa is releasing this one. So just for example, okay, maybe I'm wrong. The zona glomerulosa is releasing glucocorticoid. So you are giving glucocorticoid from outside. It will just act the same like glucocorticoid your inside. Are you getting me? Similarly, this fasciculata, if it's secreting corticosteroid and your corticosteroid are not functioning, you have to give from outside that mimic the same corticosteroid that will perform the same action. So remember this glucocorticoid, oral glucocorticoid we are going to give here, and the example is prednisone.
So glucocorticoid is prednisolone. So we can remember like GP. Like GP. This is GP. And hydrocortisone is mineralocorticoid, huh?
Yes. But must confirm, huh? We confirm from the theory. Okay. Now, which of the following medication can be used as an adjunct medication in severe cases? Now, adjunct, add therapy. So, add therapy must be antivirals. So, if the name of antiviral is there, you can go for that. Or here it's mentioned antiviral, Rotam. You can choose this one. Now, in how many weeks 85% cases of Bell palsy gain full recovery? I think it's there in MTB as well.
6 weeks. Did
No,
take
not
at
in
least 3
MTB.
months.
Here also.
It take at least 3 to 6 months, more than 6 months.
Yeah. Let me just reconfirm this one because I have seen here this one. Yeah, within 3 weeks. Within 3 weeks, you will see. So just do the ratification for this one,
No,
right?
not done 3 weeks. It takes months.
3 weeks is almost 1 month, right? See, idiopathic. If it's a reason is idiopathic, you don't know the reason. Complete recovery in approximately 85% of cases within 3 weeks. So you will go for this one. Or if you have, because sometimes we have to have more evidence, more choices. Like if you have any book reference with you, or you can go
Here
for
is it given
Nutstead.
3 weeks, but it takes months.
Yeah, but it depends upon the etiology. If etiology is mentioned idiopathic, choose 3 weeks. Otherwise, if you know the etiology, you are going to treat that one. It will take months, or maybe it will
How
take
long
years.
should we give
Sometimes Bell's palsy never recovers. Like
Yeah.
my father has. My father-in-law, he was treated with a brain tumor 40, 45, I think 50 years back. And still he has this palsy, Bell's palsy. So it depends now what etiology was of that.
He was treated for a tumor.
He was treated for the brain tumor. Yeah, the tumor was there in the temporal
He
region.
was operated.
He was operated, yes.
Maybe during surgery, the nerve got some
No,
damage.
no. That nerve has nothing to do with it. It was in the temporal region.
Okay.
Temporal and temporal, in between temporal and occipital region.
At that time, he had Bell's palsy.
He already started with this one before tumor. Yes. So before tumor, the palsy was there. He was operated with it for this one tumor, and now it's been 45, 50 years, still there. Yes, it remains there.
But it may be muscle weakness.
A lot of things you can say, but at 45 years back, he was not too much old. Now he's 70 years. So when he was operated, it's like 25 years. Yeah. So
No.
of course, that is not too much obvious. We cannot say maybe the nerve damage also happened after. We don't know at that time.
Maybe the nerve damage.
Yeah.
See, maybe the nerve damage must have recovered, but his muscles may have become weak.
Yes.
He might would have need at that time muscle exercises to
exercises which he has in
maybe.
Yes. Maybe that's the cause. Yeah.
Mm.
But again, it depends. It's a very rare case, but again, it depends on the etiology. So etiology.
So how long you will give prednisone?
No, for prednisone, it's always better to give for a shorter time period. You cannot give it for even 1 week more than 1 week. It's not recommended at all. Yeah.
Yes.
Only rehabilitation and all these cognitive exercises, they will help. Yeah. Okay, let's go back to the question. So here 3 weeks, right? Because or it should be mentioned idiopathic, then you will choose 3 weeks. Okay. Now for the next one, we'll go for the theory first. Next is hypertrophic cardiomyopathy. We'll see on page number 44. Okay, this dilated hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy, HCM and HOCM. Here today we are only discussing with this HCM, but please remember HOCM, very common recalls of HOCM where the where the question says that the patient is known athlete, he was playing in the sport and suddenly he fell down, he was having this heart attack and he died. So very clear cut, or maybe the history, like the brother is having a history of his brother who died while playing at the age of 25 years, and this brother is presenting with the symptoms of cardiomyopathy. So what you're going to choose? You're going to choose hyper obstructive cardiomyopathy. Always remember HOCM. Always, whenever there is athlete, whenever there is sports, something like that, brother, history of brother, dying because of the same athletic problem, same sports problem during the sport, something like that. Always choose HOCM, hypertrophic obstructive cardiomyopathy, because it's a genetic one. And what is the main exactly cause? This this posterior part of the heart is actually get very thick. Very thick and normal. If the normal is 1 time, then the thickening is 4 times more than the normal. So this is mainly the genetic reason, the main etiology. But hypertrophic cardiomyopathy, it's not the genetic one. So we are just going to deal with the hypertrophic cardiomyopathy right now. So for hypertrophic cardiomyopathy, the most common cause, and it's a very important recall, we are going to solve this one. The most common cause is hypertension. Hypertension, must remember. But for HOCM, nothing like that. Maybe the patient is absolutely normal, nothing. Only during heavy exercise, only during playing, walking, running, during sports, any sports, if the patient is experiencing this cardiomyopathy, then always consider HOCM. Must distinguish between this hypertrophic obstructive cardiomyopathy, so reaction to BP. So why there is hypertrophy? It's very obvious, right? Heart hypertrophies to carry load, develops difficulty relaxing in diastole, can't relax, can't receive blood, because we know very well during diastole the heart receives its own blood supply. But if heart is not relaxing at all, the coronary arteries are not going to get enough blood. They are not going to supply enough blood to the heart as well. And as a result, the heart is getting weaker and weaker, and the patient is going to experience shortness of breath, the most important symptom. So etiology, the most common cause is hypertension. Because of the hypertension, heart hypertrophies. Because of the hypertrophy of the heart cannot relax. If heart cannot relax, heart cannot receive blood. And what will happen? The patient will show shortness of breath. But hypertrophic obstructive cardiomyopathy we are not dealing here with right now, but must read this one because it's a genetic problem, especially. So you are going to hear this as per Gallup. So it must be there in the answer choices. It must be there in the presentation or in the examination findings. If you can hear this as per Gallup, there are few signs of right heart failure. You can see peripheral edema, less ascites, less enlargement of liver and spleen, but may be there. Not necessary, but you may find right heart failure signs. Now, if we just go for the all HOCM, we will not discuss this one. Hypertrophic cardiomyopathy treatment, best initial therapy for both of them. Whether it's a hypertrophic obstructive cardiomyopathy or this one, beta blockers. Always remember beta blockers. But for the diuretic, please remember this one. For the diuretic is going to help hypertrophic cardiomyopathy because here the heart is not relaxing, heart is not receiving enough blood, but it's going to harm hypertrophic obstructive cardiomyopathy. Why? Because in hyper obstructive cardiomyopathy, the reason is something different. Here is actually the thickening of the muscle. If I just go up and I will just quickly show you this one. Here the symptom is actually septum is thickened. Posterior wall of the heart is actually very thick. So here the reason is totally different. Here is only the thickening of the wall of the muscle that is not carrying enough amount of blood inside the heart. There is not something related to its self supply of the heart. So that's why you are not going to give diuretics to these patients. Otherwise, there will be too much amount of water is going to be excreted out from the body, and there will be much more worsening of the patient's condition. But in this one, in hypertrophic cardiomyopathy, the reason is hypertension. So in order to just release the pressure of the blood, you may use diuretic as a first line of therapy. As always, we are using diuretic as a first line of therapy. And beta blockers always is the best choice in both of the cases. So if we just go and solve this one. So which of the following is the best initial therapy of hypertrophic cardiomyopathy? Best initial therapy, always go for beta blockers. And which of the following is the most common cause of hypertrophic cardiomyopathy? Most common cause. Always think of hypertension. For this one, I think I have to go for the theory first. Okay, so this is heparin-induced thrombocytopenia, very important topic for the recalls. 178. Okay, so this heparin-induced thrombocytopenia, see, for this one, the patient must be on heparin because the term says heparin-induced thrombocytopenia. So the patient must be on this heparin treatment. And what kind of heparin? It must be unfractionated. We have two types of heparin, unfractionated and low molecular weight heparin. Most of the time, we always recommend to use low molecular weight heparin. But if somewhat the patient is on unfractionated heparin, then what will happen can still occur with now it's this heparin-induced thrombocytopenia is not only related to unfractionated. It may happen with the low molecular weight also, but most of the time when you see the patient is having this heparin-induced thrombocytopenia, he must be receiving his unfractionated heparin. But still it can happen with the low molecular weight as well. Now, present 5 to 10 days after start of heparin with a marked drop in platelet count more than 30%. So because it's thrombocytopenia, penia means less amount of cells. So thrombo means platelets. So there will be very less amount of platelets. Normal, if normal is 150 to 300, then it must be 30% below that. Both venous and arterial thrombosis can occur. Venous clots more common. So we can see both of them, but venous are more common. And this heparin-induced thrombocytopenia really leads to bleeding. Platelet just precipitate out. So you're not going to see massive bleeding in those patients because of thrombocytopenia. Just like the other one where we see massive bleeding because of low platelet count, here you're not going to see massive bleeding, but here you will see thrombocytopenia. There is less amount of platelets in the patient's blood. The patient may show these venous clots somewhere in the body, and if you inquire and upon investigation that the patient is on heparin, then you can think about heparin-induced thrombocytopenia. So what you're going to go for the treatment, immediately stop all heparin containing products. Can't just switch unfractionated to low molecular weight heparin. You cannot go for that. Maybe the patient is already on low molecular weight and is presenting with induced thrombocytopenia. Just stop everything. Just stop every heparin, whether it's unfractionated or low molecular weight. Direct thrombin inhibitors we are going to give to these patients instead of giving this heparin. We can give this argotraban, which is very common. After direct thrombin inhibitors started, use warfarin. Anyhow, warfarin is a good option, but we cannot just start warfarin. Say, for example, in pregnancy, you cannot give, or especially after surgery, you cannot give. So where we have good option for heparin, but what we can do if the patient is presenting with thrombocytopenia, induced thrombocytopenia, we can stop heparin first. We will change this to direct thrombin inhibitor, but that are not going to add much value to the patient. Then we can just switch to warfarin, but we cannot directly switch to warfarin, because then there will be too much difference in the INR and the patient is experiencing problems again. So do not transfuse platelet into those with heparin-induced thrombocytopenia. Why you are not transfusing? Because it may worsen the thrombosis. Again, the patient is having the problem with the clotting, right? Venous clots you are going to see, and you are going to give platelets to the patient. What will happen? It will get, the worsening of the patient's condition. The patient will much produce this thrombosis because of the increased amount of platelets there. So what is the best suited option here? Just go for this direct thrombin inhibitors. So for exam point of view, what we are going to memorize here, that whenever there is a scenario which clearly says that the patient is already on unfractionated heparin, and you can see some venous clots in the patient is presenting with some features of thrombosis, and upon investigation, you will only see decreased level of platelet, but not too much decreased level of platelet. There is no too much aggravating symptoms in the patient. Then always think of this heparin-induced thrombocytopenia. So if we just go for the question here, it says a 59-year-old man has diabetes, hypertension, dyslipidemia, and chronic renal impairment. He was admitted 5 days ago to coronary care unit for a non-ST elevation MI. So we know very well in the case of non-ST elevation MI, the most important treatment is heparin. So he must be receiving heparin because of this thing. He is receiving unfractionated heparin. Now it's clearly mentioned here, unfractionated heparin. His labs upon administration were normal. Day 5 of his admission labs shown this one. Now if we can just go quickly through this result, hemoglobin 13.1, so which is okay. Now platelet count is 65. Here you can see a massive decrease in platelet count. Like normal is 150 to 300 to 400. It's 65. WBC it's okay. Creatinine is okay. APTT is okay. INR is okay. If you think about any other thrombotic diseases, there must be some derangement in the INR, there must be some derangement in the APTT as well, and of course prothrombin time. But what if the patient, the other things are all normal, but only you see this isolated thrombocytopenia, and the patient is also on unfractionated heparin? Always think about this one. So why I'm considering this one? Because why I'm considering this heparin-induced, why I'm not considering this ITP and TTP and DIC? Of course, for DIC is very obvious. The patient must be having the symptoms of sepsis, right? But here there is nothing like that. Here the patient is only presenting. Even here, the patient is not presenting with anything. He's just gone for the normal routine investigation after his MI. After his MI, he was just undergoing this normal investigation, and there we ruled out, okay, the patient is having this low platelet count, and other rest of the black thing is normal. The INR is normal, the APTT is normal. In order to choose the diagnosis of PTP and ITP, there must be deranged INR, there must be abnormal APTT, there must be low platelet count, of course, and there must be history of bleeding as well. But here in this patient, there is no any symptom of bleeding, so that's why it's a clear-cut question of heparin-induced thrombocytopenia. So I'm sure you're getting my point. We cannot choose TTP and ITP because the presentation is not there. The bleeding is not there at all in the history. In order to choose ITP and TTP, there must be bleeding, mild bleeding, severe bleeding, but there must be bleeding, and there must be deranged INR, there must be abnormal APTT. But here all things are normal. So it's a clear-cut indication, and the use of unfractionated as well. So it's a clear-cut. Now, in known patients of heparin-induced thrombocytopenia, transfusion of which of the following blood products will worsen the thrombosis? So here, if you are going to give more, if you're going to give more platelet, there will be more thrombosis. No need, because here the main cause is heparin. The patient's platelets are working very fine. There is no any problem in the patient's platelet. It's only the heparin which is actually causing the destruction of platelets. So if you're going to give platelet from outside, what is the point? When you give platelet outside from the body, the point is that your platelets are dysfunctional. Your platelets are not working properly. But here, the cause is not because of the platelet. Here, the cause is because of the heparin. So if you are going to give platelet from outside, what will happen? The normal platelet and the one you are giving from outside, both of them will work, fast, multiply their effects, and there will be too much thrombosis. So that's why we cannot give platelets in these patients. They will worse thrombosis. Okay. Now we'll go to the next one. Next topic is Alzheimer's. For Alzheimer's, we'll just consider numbers. It's not very much in detail in MTP. And for Alzheimer's also, again, it's a neurodegenerative disease. Very, very clear scenarios. You can easily get the idea, okay, this is this scenario. So for Alzheimer, always think of dementia, always the patient is old age. And are you all there? Am I audible? Why it's showing unstable? Am I audible? Can anyone tell me?
Yes.
Yes,
Okay.
yes, sir.
Yes.
Okay.
But sometimes you're getting inaudible.
Okay, because sometimes it's showing unstable. Okay. Just let me know if I'm not audible, okay, anytime. So for Alzheimer, always, there must be an old patient, there must be some dementia, lack of memory problems, some behavior problems, some, he may be, forgetful every time. So something like that. So the scenarios are very, very common. So here we can just see the clinical features of this one. So here will be short-term memory impairment. You will see in this patient, there will be language problem. There may be some disorientation with the time, place, and person. There may be less common symptoms. They may be there, not all of the time, but you may find some aphasic problem here, apraxia, alexia. So just quickly go through the definition of this apraxia: the inability to perform coordinated, purposeful movement. Alexia, an acquired inability to read, that is the result of a defect in central language processing, an acquired inability to read properly. And this one, agnosia, inability to process sensory information that result in a failure to recognize and identify object. They cannot easily identify the objects. If you show them something, they cannot recognize them. And this acalculia, the inability to perform mathematical calculation. Of course, the old age, the problem is there. The neurodegenerative problem, neurons are degenerating, neurons are not properly coordinating with each other. You may find cognitive dysfunction. So some of the time, most of the time, you will find cognitive dysfunction related to the brain, but sometimes you may find non-cognitive as well. Say, for example, there will be too much of sleep, there will be too much of anxiety, there will be mood disturbance, there will be urinary incontinence. So these are not all the cognitive dysfunction, these are the non-cognitive, but they are associated with this one. So very clear, you can easily find in the question as well. So for the treatment point of view, what we are going to give to these patients, now again, always, when scenario comes to you that clearly indicates your scenario of Alzheimer, always consider to choose the answer of supportive treatment. You may find many recalls. I can hardly find only one recall based on this one, but there are past recalls where they are only mentioning something related to supportive care. Supportive care means that if they want to do some physical activity, engage them in physical activity, make their habits, make their routine, their sleeping time pattern should be normal, eating time and habits should be normal, because most of the time this old people who are having this problem, if you're not, if they're not sleeping properly on time, what will happen at night? They will awake and insomnia will be there, and because of that they will be more agitated, more confused. So sometimes there is no cognitive dysfunction because of the non-cognitive thing. The patient is experiencing too much problem and creating too much problem to the family members as well. So in most of the scenarios, you will see something like this, like the mother is there, the father is there, the son is there, and the son is complaining that sometimes he's very agitated, he's very depressed all the time, he's not eating properly, he's not sleeping properly, and sometimes he forgets my name, something like that. So it's always try to choose the answer which says something like supportive care. But if you find that supportive answer is not there, then choose for any pharmacological treatment. So pharmacological treatment we can give, say for example, mild to moderate cases of dementia, when there is too much memory loss, what we can give? We can give this acetylcholinesterase inhibitors. So choose for donepezil or this rivastigmine. Whenever it says everything is normal, you have already put your patient on supportive care, but there is no much difference, then only go for pharmacological. It's only advice for you, because I've seen so many recalls where it only says supportive, but there are some where there are use of medication, but it's mentioned there clearly that you have already, ask for the supportive care, and despite of being fully supported from the family members, still the patient is having this problem, then you have to choose. In case of dementia, you choose donepezil. In case of moderate to severe, may be given this one, memantine, and aggression in psychosis you can consider for antipsychotic, but that should always be low dose, because here the patient, the subject is very old, most of the time beyond 65 or 60. So you have to be very careful. If you're choosing antipsychotic, always low dose of antipsychotic. And then supportive is always supportive, lifestyle modification, this cognitive rehabilitation, physical activity improvement. So this should be the first one. Pharmacological treatment of associated symptoms. So here maybe atypical antipsychotic you're going to give to your patient if the patient is too much agitated or hallucinating or improper sleep is there. And you can also use SSRI if your patient is too much depressed. But again, I'm emphasizing choose for the supportive care, and then only if you see that despite of being fully supported, the patient is experiencing, then go for pharmacological. Started with the very low dose. Okay, so if we just go for the question. An 81-year-old man with a memory lossy, age of the patient 81, memory loss is there, dementia is there, difficulty in recognizing his grandsons, he has no cardiovascular risk factors, nothing significant. Which of the following is the most common cause of his cognitive impairment? So what you will choose? You will choose, see, for the alcohol induced, there should be some alcohol intake in the history. Parkinson's associated dementia, if it's Parkinson associated dementia, there must be something related to CNS and periphery also, motor deficit also, but there is nothing like that. Only he has problem in memory loss, right? So we cannot go for Parkinson. And again, there is no bradykinesia, there is no tremor, there is no rigidity, there is no mask-like face. There are so many things in Parkinsonism which you can easily get from the history, but there is nothing like that. Multi-infarct dementia and Alzheimer. This multi-infarct dementia, the presentation is almost always the same, but because of the multi-infarct in multiple areas, there will be multiple things in your patient. Maybe cognitive associated with non-cognitive as well. But here again, only memory loss. Only memory loss, nothing than that. So we cannot choose multi-infarct because there are no more than 2 or 3 symptoms in your patient showing that there are multiple infarct in the brain. So of course, we will go for Alzheimer's disease. Very clear scenario. Again, this scenario, an 84-year-old woman, 84, Alzheimer's disease, already known case of Alzheimer, is brought to the physician by her son for a follow-up examination. The patient lives with her son, who is her primary caregiver. The report that it's becoming gradually more difficult to care for her. She occasionally has tantrums, and there are times when she does not recognize him. She sleeps 6 to 8 hours throughout the day. Daytime nap is too much, right? And is increasingly agitated and confused at night. She has a history of hypertension, hyperlipidemia, atrial fibrillation, hypothyroidism. So she must be on so much medication, right? You can think about it. Although medications are not mentioned here, but if she's a known case of all these things, she must be on most of the medications. Now, physical examination shows no abnormalities. Which of the following recommendation is most appropriate at this time? So always think of the supportive and then go to pharmacological, but that should be minimal one. So refer for cognitive behavioral therapy, adhere to regular sleep schedule, start sleep medication, don't do anything. So what do you think? If anyone can explain this one, what you're going to do?
Answer will be B. Adhere to a regular sleep schedule.
Very good. Why you have chosen this one?
Because if she will sleep at night, then she'll not be agitated and confused.
Yes, very obvious here. Because daytime she's sleeping too much. The daytime only nap should be in between 1 to 2 hours, not more than that. And even though old people they don't prefer to sleep, during the daytime. They usually want to go to bed early and rise early. So, but anyhow, because of her sleeping pattern, we must have to regulate the sleeping pattern. If that doesn't work, we'll go for cognitive behavioral therapy. If that doesn't work, then only we can think about sleep medication, but not now. So here we will go for schedule. Okay, a 65-year-old man who, okay, for this one, we'll quickly go through the theory. Okay, that's the last thing. And we will go for MTB step 2. Direct book 5th edition 287. It's very for the vaccination, for the screening. Please, you have to just jot it down by yourself somewhere, because most of the time they're asking for the screening test. Ears are very important when you're going to re-screen the patient, and especially vaccination at which age you are going to give to your patient. So you have to make notes of this one, especially for yourself, so you can revise at the end. So here you'll just go to this one, pneumococcal vaccination. Pneumococcal vaccination, everyone who is above 65 years of age should receive there are two forms of pneumococcal vaccination. One is 13 polyvalent vaccine, that is called PCV13, and other one is polysaccharide pneumococcal vaccine, that is PPSV23. So remember, these two strands of vaccine should be given to a patient, but first you will give 13 valent, then after 6 to 12 months you will give 23 valent. So all the patients who ages between 65 and more than that, you will give 13 valent vaccine first, and then after 12 months you will give 23 valent. But what if the patient is having some other conditions? So say for example, if the patient is a known case of chronic heart, if the patient is having any liver pathology, kidney pathology, lung disease, they should be vaccinated as soon as you confirm the diagnosis. As soon as the patient's diagnosis confirmed that he's having alcoholic fatty liver, or he's having chronic heart or kidney disease, just give this pneumococcal vaccine at that age. Maybe the age of the patient at that time when he's diagnosed with asthma is 30 years. No problem. He's 30 years, but he is asthmatic, exacerbation was there, then you have to give pneumococcal vaccine. Otherwise, if the patient is completely normal, no pathology, nothing in there, at the age of 65 you will give. But if the patient is having any problem with the liver, kidney, heart and lung, you have to give on that particular time period when you have diagnosed your patient. So this one, regardless of age. Now other reasons to vaccinate, not only this one, when the patient is having sickle cell anemia, when the patient is having a blood disorder, leukemia, lymphoma, HIV patient, the diabetic patient, immunosuppressive patients, corticosteroid users, AIDS patients. So these are all the conditions where we have to give pneumococcal vaccine rather than the age of the patient. Don't go for the age of the patient. Just think about this one. The patient is alcoholic, the patient is IV abuser, the patient is immunosuppressive, the patient is having leukemia, the patient is having sickle cell disease. So you have to give pneumococcal vaccine, whatever the age is there. And what is the protocol? You will start with the 13 valent. After 12 months, you will give 23. Now, in a CSF leak patient and any cochlear implantation recipient, we have to give. So there are certain conditions mentioned here where you have to give. rather than the age of the patient. Now, those who are generally healthy should receive a dose at the age of 65. Nothing in there, your patient is absolutely normal. Wait till 65 years and then you will give. Use the 13 first, then 23. Now, if the first vaccination was given before age 65, say for example, chronic heart failure patient. So at the time the patient was 55. So you will give 13, and then what you will do? Now, once he becomes 65, you have to give the second dose as well. But you need to calculate the dose interval. Here, the other condition previously, a second dose should also be given 5 years after the first dose. So, say for example, if the patient is having sickle cell anemia was diagnosed at the age of, say for example, at the age of 12 years, very early in the beginning, very early age, sickle cell anemia was diagnosed. So, you have given pneumococcal at that time. 12 months, 13 valent first, 12 after 12 months, this 23 valent. Now, when the child reaches to the age of 65, again you have to give the second dose. Second dose in the same way, where you will give this one, 13 valent, and then after 13 valent. No. Here you will not give 13 valent, then 23. Here you will only give 23 valent. That's again very important. Here it's not mentioned here, but remember this point. When you are going to repeat the second dose, you are not going to give 13 valent first. You will just give 23 valent. No need for 13 valent then, because it's going to be considered as a booster dose. So second dose should also be given 5 years after the first dose. Now again, this is very important. If the first vaccination was given before age 65 or with the other conditions previously described, a second dose should also be given 5 years after the first dose. Now, again, here are two conditions. The one condition is that, say for example, anybody who is going to diagnose with something at the age of 40 years. So 40 years means that it's before 65 years. So you will give them vaccine, and you will give them vaccine after 5 years. As per this statement, you have to give them vaccine after 5 years till he gets the age of 65, and after 65 you will just give only one dose of 23 valent. Let me find out that thing for you. I will just give it to you. But for now, here, just memorize this one, that before the age of 65, whenever you have given the vaccine, just repeat the second dose of vaccine after 5 years. But there is also a recommendation that when the patient reaches to the age of 65, then after 65 you have to give second dose, and that dose is only of 23 valent. So let me find out that resource for you. I will just give it to you maybe inshallah tomorrow. But for now, only for reading this purpose, this vaccination, just memorize this thing, that if the patient is 65 with nothing, no problem, give 13 valent, and after 12 months, give 23 valent. If the patient is having any problem listed above and he is not 65, below 65, just give him vaccine. The same protocol, 13 first and then 23, and then after 5 years, again you will give the second dose. But for second dose, always remember, we are not going to give 13 valent. We have to give only one, and that is 23 valent. It's not mentioning here, but I will give you that reference where you will find that we have to give only the 23 valent, not the 13 valent. So based on MTP, if we just solve the question. So here it says 65-year-old man who is asymptomatic and has no known allergy. So it's a very clear-cut question. What is the best approach for pneumococcal vaccination? So 65 years, totally healthy patient, you will give 13, and then after 12 months, you will give 23. So PCV followed by PPSV. And for this question, if the first pneumococcal vaccination was given before age 65, a second dose should be given after which time interval? So this is again very clear. 65 before, the patient must have received first, then you will give after 5 years the second dose. But remember this point, that which vaccine you are going to give after 5 years, it should be a 23 valent. For this, I will provide you a reference with that, because we cannot find this in MTB. So any question so far related to this one? Very quiet, huh? All of you are bored now. Any question so far for this one? Can we stop here now?
Yes, bored and sleepy. Today I sleepy.
But see, this vaccination questions, this screening questions, they
No,
require.
but Dr. Hira, we should do one system at the time like this. It's defining here and there and going here, there is difficult.
Yeah, because we are doing only recalls, darling. We are not doing theory. That is the reason. If we are doing theory, we have to go step by step. But
we can do step by step. So we can study one system like this.
Yeah, so it's going to be beneficial for those who are appearing in this month, inshallah. So like Dr. Sana must be going to get benefit from this one, and you will also get once you do the theory by yourself. Yeah,
if we do in the systemic way.
Yeah.
How we can find this? I don't know the pages. From where we should find the pages.
So see, this one I will share you. Don't worry. So whatever we are doing now, but my main focus is not to teach you, only to give you some points, some important clues, so that you can go through your theory or on your own, and you will find it easy when you're doing, broken recalls. The whole purpose is that. Otherwise, I can go for the whole, teaching, no problem, step by step. But we don't have time for that. Not you, not me. So it's okay. If you are thinking that you are not coping with it, it's okay. You can just go with the theory first, and then you can go for the recording later. So maybe that will help you. So let me just stop the recording.